For the last 3 months, we've been delighted to have 2 of the students from the University of Keele working with us on identifying the demographics of Smith-Magenis syndrome throughout the UK. We've got some fantastic results on there, and what I will do is I'll hand over to Natasha and Xheni to take us through it.
Hi everyone, so I'm Natasha Craven and I'm a third year biomedical science student at Keele.
I'm Xheni and I'm a neuroscience student at Keele in my final year now.
Brilliant. So the aim of the study for the SMS Foundation was to establish a definitive demographic profile across the UK. We knew previously through work done by Frank Greenberg that the estimated incidence rate is 1 in 15,000 to 25,000 through a study done on the state of Texas in America. And so currently our foundation membership of 300 individuals is quite a large underestimate of the total UK SMS population. Here is a list of our objectives which we developed for the project, and we will be later discussing how we may have completed, or in some cases not completed, some of these objectives. And so this was our starting point. We had 302 individuals known to the foundation to have SMS. These individuals range from birth age to about 65 years of age, and our current prevalence rate to the foundation is vastly different from the estimated one, being 1 in 220,000 compared to 1 in 15 to 25,000. And so with this starting point for the project, we designed freedom of information requests to be sent out across the country to the local authorities, genetic laboratories, health authorities, and also later down the line, we sent them out to the CCG organisations in England as well.
So my role in this project was to send the freedom of information requests to local authorities, which you can see in the table, the various number of local authorities found in each part of the UK, and the replies, some that were COVID deferrals, some that gave data, some that didn't, and the ones that replied that it was too expensive. But in summary, 75% of the local authorities replied, and from that 75%, only 10% was a positive reply with some data. So mainly the local authorities responded that information was not held, and they referred me or us in general to the NHS clinical commissioning groups. And sometimes they just did not hold the data because the services that they were offering were determined by individual circumstances. Some could not respond due to COVID, and some would exceed the cost limit of a FOIA request. But we have a few positive responses, such as the Dorset County Council, which gave us a total of 14 new individuals that, combined with the foundation data, give us a number of 18 SMS individuals. That gives us a prevalence rate of 1 in 21,000. So the lesson that we learned from sending FOIA requests to local authorities was that local authorities do not have the ready access to syndrome diagnostic data. Most of their services are determined by individual circumstances, and they also assume that the NHS or clinical commissioning group hold the information when it's not always true.
And so my role was to tackle the health side of the project. Here is the scope of data received from Scotland. And although we still have some replies coming through due to delays caused by the current pandemic, Scotland has generally provided us with a full picture, allowing us to increase our original foundation number from 22 to 80 to this date. Here is the scope for Wales, as seen previously with Scotland. We received all of the replies back from Wales, although there were a large number of the organisations which could not provide us with data. And the data we received were somewhat able to confirm our original foundation number of 14 individuals. Northern Ireland were able to provide a similar picture to Wales, and of the organisations who were able to respond, we were able to find 4 more individuals with SMS, boosting our original foundation number of 11 to 15. And finally, with England, due to there being a vast number more organisations that we needed to contact, we were able to further identify 157 individuals, boosting our original foundation number of 249 to 406 individuals. And so what we learned from this project is that sometimes the health authorities held the data in their respective countries, as seen in Scotland and Wales. However, others do not. And in Northern Ireland in particular, the Health and Social Care Trusts do not hold the data, as well as the clinical commissioning groups in England not holding the data either. This variation in the sources which hold the data was quite interesting, although we did come across a case where, upon first contacting a health authority and local authority, they suggested that we contacted the CCG, and upon doing so, they suggested that we reach back out to the health authority for the information. So it seemed that they themselves were unsure where the data was held. And due to some of the responses giving data to the ICD-10 codes 935 and 9388, as well as NHS Digital offering data in relation to these codes also, this gave us the idea of trying to obtain an ICD-10 code for SMS, or potentially an ICD-11 code in the new live system.
So here are again the objectives of the study. One of the first objectives was to profile SMS across the UK by area and age. You can see that the first graph of the UK SMS age distribution is skewed toward the left on preschool children and school-aged children, but this profile is actually consistent with the year of test and age when a person was tested. For example, we know that a person is usually tested from birth to 5 years old is the peak of testing. So if a person was tested during year 2000, just because testing was more prevalent at the time, we would see right now a peak in about 20-25 years old, as we can see here, and also at younger ages. But we see the peaks taper down during older ages, meaning that there is not much testing done on older people. We also know that the oldest person identified from the replies is over 80 years old, meaning that SMS might not interfere with life expectancy of a person. And when we compare the graph of the age distribution of SMS with a normal age demographic, we would expect them to be kind of similar. We can see that the SMS one is tapering off, but this is just due to, we think, a lack of testing of older ages. So here we can see a graph of the SMS diagnosis by year, and we can notice that as the development on genetic testing went up, also did the number of diagnoses by year of SMS. We can see some important dates there, such as 1986, when there was the first published case of the deletion of the 70p11.2, or in 1990, where when the Human Genome Project started, and then in 2002, the human genome was mapped. And we can see also in 2004 the chromosome microarray analysis, and we can kind of see a pattern here of an increasing number of diagnoses by year as with the development in genetic testing and DNA knowledge goes on. Another aim of this project was to validate the 1 in 15 to 25,000 incident rate. We did this by collecting the data that was given to us by health authorities and local authorities and the population under these authorities. So for example, for the Forth Valley Health Authority, we have 22 individuals with SMS, which give us a prevalence rate of 1 in 14,000. And for example, in Manchester, we have 69 individuals with SMS, which gives us a prevalence rate of 1 in 19,750. And we can see by these numbers here that Smith-Magenis syndrome is significantly underdiagnosed and underreported. So here we are trying also to identify some geographical layers for support services and activities. You can see that the map on the left represents the distribution of the SMS population in the UK by gradient. You can see the dark blue spots are London and Manchester, and they have a high density because we identified a high number of people in those areas. While the areas with a lighter blue have a less dense population of individuals with SMS. And the gray areas, basically, we do not have any data on them. So we combined the gathered data throughout the study with the known data of the foundation, and we try to identify these clusters of individuals with the Smith-Magenis syndrome because we wanted to create some activities aimed to families and changing the foundation member, like making the foundation members aligned with the population densities. But there is a lack of identification within the local authorities, which could make it difficult to provide these regionally oriented support services. This graph is here to give a bigger picture of all the data that we gathered. You can see the number of individuals on the y-axis and the UK countries in the x-axis. And the yellow bars represent the number of individuals known in each country before this project started. And the blue ones represent after the project was completed, the number of people right now known in those areas. And we can see how many we managed to identify. The one where only UK is written under the name UK on the x-axis are actually individuals that do not have a known location in the UK. Here is another map that we can use to identify geographical areas for support. With if you read what is written on the right, you can see that we are dividing each country in different areas, so we can manage to spot areas with higher densities and support with services and activities aimed for those areas. Another aim was to create information for the newly diagnosed families relevant to the age when diagnosed. And we can see in this graph that the age of diagnosis occurs mainly during the early years from 0 to 5. And this should be age band, which should be a priority for guidance and support. The diagnosis during education remains significant, and adult diagnosis is more even. We also aim to assess the crossover of registration between genetic laboratories, health authorities, and local authorities. However, this was inconclusive because there is insufficient data to be able to provide an analysis of the overlaid of identified SMS population. but and also there is the retention of genetic diagnosis data is generally considered to fall within health agencies, but even then the retention and access is highly variable by the agencies concerned. We aim to scope the potential size of a patient registry. Now the total number of individuals diagnosed with SMS known to us is 526. The number included in genetic clinic data return was 153. So initial size of a UK patient registry is unlikely to exceed the 200 individuals based on only the genetic clinic data. However, a more general patient registry for SMS would not exceed the 750 individuals. So we were trying to develop training for professionals and families, but the challenge is now to reach professional audiences. And there is a lack of accessible information on individuals with SMS, which leads the approach to needing to provide training around the individual rather than to a larger cluster audience. However, the foundation has 2 current inquiries for training for different adult care services in Dorset.
And so for the next steps, in the early months of next year, information and resources are to be sent to all Scottish hospitals, genetic centres, GPs, local authorities, as well as social work and education departments to raise awareness of the syndrome. Because what we found in particular was there was such a large difference between the original foundation number of 22 in Scotland to the new found number, which is 80, that we really wanted to start and focus there. A regional representatives programme has also been established across the UK through the NHS regions, which has been organised by the SMS Foundation, where SMS families lead these specific regions and areas, acting as a contact point and a leader even for those areas. The demographic study details have also been shared with the SMS international organisations as well as Genetic Alliance, and will be further shared with the foundation members at the SMS conference, which is scheduled for May 2021. Additionally, we are looking into ways to publish our data methods in journals, and because the data that we receive from the study is so, we're very proud of it. It is now also being used to support grant applications as well. And an investigation into establishing a patient registry is also scheduled to be explored in 2021.